We're going to talk about opioid use disorders and the management of acute and chronic pain today. And I'm borrowing these slides from Dr. Bott, which I'm sure he wouldn't mind. So the objectives today are to describe and understand the clinical import and utility of the comorbidity of opioid use disorders and pain. Understand how opioid replacement therapies do not preclude the need for effective pain management. Describe and apply strategies to manage pain in patients on opioid replacement therapies. So we'll start with the prevalence. Just in terms of percentage of patients with opioid use disorders who have chronic pain, and that ranges from about 37% all the way up to 64%, or about 2/3. And the overriding takeaway point here is that typically pain can be a precipitating factor in the development of opioid use disorder, and that pain often occurs first. Patients who had chronic pain before onset of opioid use disorder have high rates of mental disorders and other health conditions. Patients who had opioid use disorder before the onset of pain are more likely to have other substance use disorders, HIV, and Hep C. So in terms of acute pain management, this is a drawing from a patient who was trying to illustrate their experience with chronic pain, and clearly the message that's coming through here is that they were feeling overwhelmed, and I think that's a good illustration of how people feel and the empathy that's needed to approach these patients. So we can do a little vignette just to provide some color to our talk today. AN is a 45-year-old female, status post-shoulder surgery, the history of OUD, previously on methadone twice, stopped treatment and relapsed both times, was using about 0.5 gram of heroin 2 to 3 times a day prior to her surgery, and was on morphine continuous infusion, about 4 milligrams per hour, plus 10 milligrams IV Q4 PRN. She requests more pain medications, reported pain 9 out of 10. She's in tears with stable vital signs. And then someone on the unit mentioned she is drug seeking. She's already getting more pain meds than any other patient on the unit. She doesn't need more. Besides, she is an addict and we don't want to worsen her addiction. So, obviously important to keep in mind the prevailing narrative around people with opioid use disorder and chronic pain often involves a significant amount of stigma and discrimination. Commonly held beliefs as such include that acute pain is frequently undertreated as a result, up to 60% in inpatient settings, and even more so in patients with addictions. Addictions are often seen by healthcare professionals as primarily a social problem that requires law enforcement rather than a health problem that requires prevention and treatment. And this perceived controllability and that people are making a conscious choice translates into blame and stigma. And these patients are often viewed as manipulative. So the suggested approach is to accept the patient's self-reported pain. Pain behaviors vary widely, and vital signs are not a very reliable indicator of pain intensity. Consider addiction versus pseudo-addiction versus physiologic dependence. If required, do not withhold opiate analgesics from people with addictions. There's no data showing that acute pain management will worsen addiction. However, untreated pain often leads to cravings for opioids, which augments the risk of relapse. 2 studies of patients on methadone show that opioid pain management for acute pain did not increase chances of relapse. In fact, if patients are on baseline opioids, they're going to have a tolerance, and therefore in the setting of acute pain, higher doses of opioids may be needed. The risk of respiratory depression may be lower in patients who are opioid tolerant. And remember that opioid agonist treatment will treat baseline addiction, not acute pain. So acute pain management in the emergency setting, you can use the column on the left as a guide. So we typically always recommend that people continue their maintenance buprenorphine, but you can divide it into higher frequency doses as long as you maintain the same total daily dose. But splitting it up offers better pain coverage. And then there's non-opioid analgesia, such as maxing out acetaminophen and ibuprofen, especially for our young residents. You know, you always want to make sure you do that before calling in a pain consult so that you don't get yelled at by the pain fellow. And then, you know, there are also other, there's an array of non-opioid analgesics as well, including rice, trigger point injections, lidocaine, gabapentinoids, regional nerve blocks, e.g. for like rib fractures and things like that, and hematoma blocks. And then there's also subdissociative ketamine as well. If greater pain control is needed, you know, there are additional opioids. Even though buprenorphine has a pretty significant binding affinity, things like fentanyl and Dilaudid will certainly compete with the buprenorphine and provide additional pain control. And then you can also start to increase the sublingual bup or start IV bup. And as I mentioned, again, we have, there's also clonidine, Precedex, and other types of nerve blocks. Mastering non-opioid techniques of pain management is particularly important in patients on medications for opioid use disorder. Patients on MOUD have a high opioid tolerance. Naltrexone has a very high mu receptor binding affinity. Pain is difficult to treat with most opioids. And methadone, of note, has a particularly long half-life and is a full opioid agonist. For patients that are on methadone and you need to manage their pain acutely, this can be daunting for some folks, but I think the first step to remember is to go ahead and verify their dose from the home clinic. And if the dose cannot be verified, it's safer to break up the self-reported dose into TID to QID dosing rather than giving it all at once in the morning as they might receive at their methadone clinic. Plus, you can then add in other short-acting opioids for breakthrough pain, such as oxycodone. Gradually increasing methadone dose. Do not administer buprenorphine because as a partial agonist with a high binding affinity, it's going to precipitate withdrawals in the setting of someone who's on chronic methadone. Patients unable to take their oral dose should be given IV methadone. The IV dose should be reduced by 1/2 to 2/3 and be given in divided dose every 6 to 8 hours. And also consider, you know, methadone for pain can be prescribed by any clinician with a Schedule II DEA license. But methadone for addiction, however, is once-a-day dosing only through an opioid treatment program, i.e. a methadone clinic like ASAP. For people on buprenorphine and managing their acute pain, you know, we're employing all known opioid modalities for pain management. And as we discussed a little bit, you know, we're going to start breaking down their total daily dose into more frequent administrations to provide better pain coverage. And you may also temporarily increase the dose of buprenorphine. Consider IV buprenorphine. And again, you can always augment with short-acting opioids with high mu receptor binding affinity, particularly fentanyl or Dilaudid. And consider consulting an addiction medicine expert or a pain expert. So for perioperative management, and this may be I may be jumping ahead regarding a slide coming up, but the most recent evidence suggests that patients should not discontinue their buprenorphine if they are on buprenorphine or Suboxone for surgeries. And this comes up a lot. I think the general consensus born out of some studies that were done in San Francisco at UCSF suggests that you can go ahead and reduce people's buprenorphine down to 12 or 16 milligrams, and then they can manage perioperative pain with things like fentanyl, Dilaudid, and then in the post-operative period, only for 3 to 5 days, not forever, or not for an extended period, using PRN oxycodone for breakthrough pain can be helpful, but again, you don't want to fully discontinue their buprenorphine even around surgeries, because the risk of relapse is too significant. And in light of the fact that overdoses with fentanyl are on the rise and essentially represent the leading cause of death under the age of 50, predisposing a patient to relapse and overdoses certainly a suboptimal potential outcome. So as I was afraid of, I jumped ahead a little bit, but buprenorphine is a powerful analgesic that can be combined synergistically with other opioids. Buprenorphine on board first and maintained through the perioperative and pre-op period. This is the article that I mentioned, and I was wrong. It wasn't UCSF, it was Stanford, but close enough. Naltrexone and acute pain management. So as a reminder, naltrexone and Vivitrol in particular is one of the 3 FDA-approved medicines for opioid use disorder, in addition to methadone and buprenorphine. It's much less common for the treatment of opioid use disorder, just because it's hard to initiate in people who are chronically using opioids, but it does occur. And it's unique in that it's mu opioid receptor antagonist. So it's actually blocking that receptor rather than activating it like buprenorphine and methadone do. Patients should be advised to carry a patient alert card that informs medical personnel if they are taking injectable naltrexone. And this is important, right? Because as an antagonist, it's going to block any emergency acute pain opioids that are trying to be used in that setting. So the suggested plan for pain management is regional anesthesia or use of non-opioid analgesics. People often use ketamine in this situation because the opioids are just not going to work, particularly if the Vivitrol, i.e. the long-acting injectable form of the naltrexone, is on board. In an emergency situation requiring opioid analgesia, the amount of opioid required may be greater than usual, and the resulting respiratory depression may be deeper and more prolonged. So obviously a tricky situation. A rapidly acting opioid analgesic that minimizes the duration of respiratory depression is preferred. Patients should be closely monitored by trained personnel in a setting equipped for cardiopulmonary resuscitation. And for these reasons, this is why I certainly would potentially consider using ketamine more aggressively instead of opioids in the setting of naltrexone. So this is kind of just a little bit of a recap, and I'm going to skip this just in the interest of time because I have about 6 minutes left here. And these slides will be made available to you. And you can review these because I don't want to get too much into the weeds. Again, these are all alternative intraoperative non-opioid pharmacologic agents for multimodal analgesia. Let's just get into a little bit of chronic pain management. And we have another illustration here, kind of giving you a feel and maybe generating a little bit of empathy for these folks who are struggling with chronic pain. So the basic considerations are to remember: a history of opioid use disorders is the single biggest predictor of aberrant behaviors to prescribed opioids. Consider consulting a pain management specialist. Use a multidisciplinary team approach. Use non-opioid and adjuvant medications first, such as NSAIDs, SNRIs. I particularly like Cymbalta or duloxetine in this case. TCAs such as amitriptyline can be helpful. Membrane stabilizing agents, and then certainly gabapentin and pregabalin. Use non-pharmacologic therapies. Particularly acceptance and commitment therapy is very evidence-based for helping people reframe and come to terms with and proactively manage themselves, such as that the pain doesn't have a huge negative impact on their quality of life and daily functioning. And then things like yoga, meditation, pool therapy, acupuncture, traditional healing, etc., as well as other more interesting interventions such as nerve blocks and spinal cord stimulators, etc. So of course, we always want to be doing responsible opioid prescribing, using the PMP, making sure patients have access to Narcan, making sure they're not overusing, overtaking, running out of their medications first. But, you know, these aren't necessarily reasons to cut people off, and very rarely do I. But, you know, you just want to be aware and making sure that people aren't doctor shopping, et cetera, and diverting potentially if it can be avoided. I'm going to skip this in the interest of time. Buprenorphine and chronic pain. So I think the main takeaway here is that, again, is that buprenorphine is very effective for chronic pain. And typically I split it up into TID or QID dosing, and that tends to be the best for pain control. People over at the pain clinic at UNM do this frequently, such as like 4Q4 or 6Q4, or even 8 milligrams QID is acceptable as kind of like a max dose. So I think I may try to wrap up here just to leave room for some questions. But I will say that, you know, if you have a patient with opioid use disorder, buprenorphine and methadone are both highly effective. Methadone may not be as applicable for this audience because it's mainly often used at OTPs and people may not be as familiar with it. But, you know, that TID or QID dosing of buprenorphine is very effective. And then the things that I find myself also using very frequently are the duloxetine, gabapentin, maxing out your ibuprofen and your acetaminophen, and things of that nature. So with that, I think I'm going to wrap it up a little bit early.